All right, welcome to this high-yield explainer. Look, if you're a med student staring down a mountain of a syllabus right now, you're in the exact right place. Today, we're doing a rapid-fire board review on a topic that examiners absolutely love to test, Leishmaniasis. We're cutting all the fluff and getting straight to the core concepts you actually need to know.
Because here's the reality, right? Medical exams aren't just testing your raw knowledge. They are actively testing your ability to spot perfectly laid traps. So in this review, we're going to hunt down and dodge the 10 most common, highly tested clinical and diagnostic traps hidden in this one disease. Let's secure those points.
Okay, here's our game plan for today. First, the bug and the body. Then, Kala-Azar and clinical forms. After that, the PKDL reservoir trap. Then we'll hit dangerous diagnostic pitfalls, and finally, treatment and teratogens.
Section 1. The bug and the body. Let's lock down the microbiology fundamentals first, because this is exactly where the first traps are laid. So, jumping right into trap number 2, you absolutely have to know the difference between the promastigote and the amastigote forms of the parasite. It's night and day. The promastigote, it's flagellated, it's extracellular, and it lives inside the sandfly vector. But the amastigote is a totally different beast. It literally loses that flagellum, so it's non-flagellated, and it lives entirely inside the cells, specifically hiding out inside the human host's macrophages. Do not mix these two up.
And this whole process is honestly a literal hostile takeover. Step 1, the female sandfly bites and injects the promastigote. Step 2, your body's own macrophages sweep in to eat it, but instead of dying, the parasite just transforms into the amastigote right inside the cell. And step 3, it replicates, bursts the macrophage open, and spreads. It's using your own immune system as a Trojan horse.
Which brings us directly to trap number 9, the immunology trap. Now, normally, a Th1 immune response is what protects you, right? But examiners will try to bait you with IL-10. Listen, interleukin-10 is an immunosuppressive cytokine. In visceral leishmaniasis, IL-10 is the major bad guy. It actively downregulates nitric oxide and conditions the macrophages so the parasite can survive and thrive. Don't fall for it on test day.
Section 2. Kala-Azar and clinical forms. It's time to shift from the microscopic bug to what your patient is actually going to look like in the clinic. We essentially have 3 main clinical buckets to contrast. You've got visceral leishmaniasis, which means massive organomegaly and system failure. Then cutaneous leishmaniasis, that's the most common one, presenting as a classic painless ulcer with raised margins that usually just heals on its own. And finally, mucosal leishmaniasis, which is notorious for severe, non-healing cartilage destruction in the nose and throat.
So let's snap our attention to that deadliest presentation for trap number 1. Here's a classic Socratic question they love to throw at you. What exactly is black fever, and why is it considered an AIDS-defining illness?
Well, black fever is Kala-Azar. It's the absolute most severe form of visceral leishmaniasis, named after the characteristic dark skin hyperpigmentation these patients develop. But for the boards, your buzzwords are massive splenomegaly, pancytopenia, meaning literally all your blood cell lines are wiped out, and hypergammaglobulinemia. If left untreated, it's fatal. And if a patient has an HIV co-infection, it is 100% fatal without treatment. Absolutely 100%, which is exactly why it is officially classified as an AIDS-defining illness.
All right, hitting trap number 7. This is about mucosal leishmaniasis, also known as espundia. The trick here is twofold: geography and prognosis. First, this presentation is almost exclusively found in the Americas. Think Amazon basin to Central America. Second, unlike the cutaneous form, these lesions do not heal spontaneously. They cause horrific destruction of the nasal cartilage. It collapses the nasal bridge into what's known as a tapir nose because it ends up looking exactly like the snout of that animal.
Moving to Section 3, the PKDL reservoir trap. Let's look at the post-infection aftermath.
Examiners absolutely love this epidemiology question. It's trap number 8. After a patient is successfully treated and completely cured of visceral leishmaniasis, who actually maintains the endemic cycle in the community?
The answer, it's the patients who develop PKDL, or post-Kala-Azar dermal leishmaniasis. In places like India and East Africa, up to 50% of cured patients can develop these skin nodules months or even years later. And the catch is, those nodules are absolutely packed with parasites. So, these PKDL patients act as the active human transmission reservoir. They are literally the ones keeping the endemic cycle alive.
Section 4. Dangerous diagnostic pitfalls. Let's see how this builds into our clinical workflow.
Diagnosing this is a classic risk versus reward scenario, and it perfectly sets up trap number 4. You'll definitely be asked, what is the single most sensitive tissue aspirate, and why do clinicians actively avoid doing it?
So the gold standard is the splenic aspirate. It's over 95% sensitive. But remember the clinical picture we just painted? Massive splenomegaly, pancytopenia, meaning their platelets are completely tanked. Sticking a needle into that spleen carries a massive, life-threatening hemorrhage risk. So in the real world, we compromise. We use a bone marrow aspirate instead. It's much less sensitive, around 60 to 85%, but it is vastly safer for the patient.
Now for trap number 3, the false security of rapid field tests. The RK39 rapid diagnostic test is amazing for an initial diagnosis, right? Gives results in 15 minutes. But here's the trick. Can you use it to confirm a clinical cure or to detect a relapse?
No, definitively no. The antibodies for RK39 stay positive in the blood for years after a patient is completely cured, so a positive test tells you absolutely nothing about their current active disease state. And watch out for this 50% statistic. In patients with an HIV co-infection, this serology test can be completely negative up to 50% of the time. You just cannot rely on it if they have HIV, and you definitely can't use it to monitor a cure.
Final section, treatment and teratogens. The pharmacology here is basically a minefield of warnings.
Let's rapid-fire clear our last 3 traps right now. Trap 5, miltefosine. It's a huge breakthrough because it's an oral drug, but it is highly teratogenic, strictly contraindicated in pregnancy, and it has such a long half-life that females need contraception for 5 full months post-treatment. Trap 6, regional resistance. Antimonials are usually first line, but there is massive resistance in Bihar, India. If the vignette mentions Bihar, your answer is liposomal amphotericin B. And finally, trap 10, species exceptions. For Leishmania guyanensis, use pentamidine. For Leishmania ethiopica, use parmomycin.
And boom, just like that, we've systematically dismantled the top 10 Leishmaniasis clinical traps. From the intracellular Trojan horse of the amastigote to the taper nose of Aspundia, right down to the teratogenic dangers of miltefosine. You have the blueprint now to conquer this disease on your exams. But I'll leave you with this final thought. When you're sitting in that exam and you see a patient with massive splenomegaly and a totally negative rapid test, are you going to remember the hidden HIV trap we just exposed? Keep reviewing this explainer, stay sharp, and go secure those points.